Good day, my name is Imelda Williams. Today I'm going to talk to you about image interpretation of the hand and the fingers, and as usual the focus will be on traumatic conditions. I've highlighted some of the references that I've used for this presentation. You'll have electronic access to Chan's book, and in that one it's chapter 2, as well as Rabies, Accident and Emergency Radiology. And for this presentation you need to focus on chapter 10, and then I've also indicated the pages that you need to consult in the image interpretation workbook. I've also highlighted some other resources which would be very useful. So I hope at the end of this session that you'll be able to consider mechanisms of injury when you look at x-rays of the hand and fingers, and then apply your ABC search strategy. Also that you will be confident in identifying the radiographic anatomy of the hand and fingers on all of the radiographic projections, and then start to identify common fractures and dislocations of the hand and fingers. So going to the ABC search strategy. So for adequacy, really important that you check that you've got the correct views. For example, if you have a request for a finger, for a single finger, you should always include an AP, a lateral and an oblique. And for example, if a hand is requested and they want to see where there's a fracture of the thumb, you know that you need to do dedicated thumb views. Referring to the alignment, it's important that you check the relationship of each bone on all of the projections, and then also check the alignment, especially on the lateral view, so that you can exclude dislocations or subluxations, and especially around the CMC joints. For bone, trace the contours so to see if there's any steps or breaks in the cortex, and then search through the trabecular pattern of the bone to see if there's any changes in density that would indicate a fracture, for example, lucent or sclerotic changes. Also be aware of vascular or otherwise named nutrient grooves, as these could mimic fractures. They appear as lucent lines and will only be visible from one part of the cortex and not on both sides, and normally they also have a sclerotic border. Then for cartilage and joints, check for uniform joint spaces, and then if there's any narrowing in the joint spaces, remember this could be positional, so it could be technical or it could be pathology. For the soft tissue, check for any signs of soft tissue swelling, as that could indicate the area that you need to look at very carefully, but also look for signs of any foreign bodies, for example, a glass in the soft tissue. It's also important to be aware of often missed fractures or dislocations. The hamate is one of those, and fractures at the bases of the fourth and fifth metacarpals, as well as dislocations of the fourth and fifth carpal metacarpal joints. Here I've provided a number of images, and this is from Bontrager. So I've provided the finger images with the radiographic anatomy outlined, but for yourself it would be useful if you complete the missing labels on the PA of the hand. Crushing, twisting and avulsive forces are quite common mechanisms of injury associated with the hand and fingers. Common fractures are fractures to the tufts, the shafts of the bones, and then also avulsion fractures. And these avulsion fractures could be either dorsal or volar, and then dislocations or subluxations. It's important to distinguish whether the fractures are extra articular. It means it doesn't cross the articular surface. That means that the treatment would normally be close reduction, or whether it's an intra-articular fracture, because that would often be an open reduction. Phalangeal fracture dislocations can result in reduced motion and significant loss of function, so it's important that these are described properly. The first and the fifth metacarpals are areas of fractures which are most common, and the metacarpal fractures makes up about 30 to 40% of hand fractures, with the fifth metacarpal neck about 10% of all hand fractures. In the shaft, the fractures are often spiral, and if they are spiral, they often cause shortening of that bone, and then also leads to instability. We are now going to look at some of the common fractures. So one that you would probably have heard of and have seen is the Bennett's fracture. This is a two-piece intra-articular fracture. It's at the base of the thumb and is also associated with dorsolateral dislocation at the base of the thumb. Rolando's fracture is in the same position where you would find a Bennett's fracture. However, it's a comminuted fracture. It's intra-articular and has either a Y, as in this case, or a V or a T configuration. Boxer's fractures are commonly known as a Brawler's fracture. The two areas where that happen quite often is the fourth or the fifth metacarpal, and in this case you can see it's at the neck of the fifth metacarpal. So the comment for this one is you would see that there's volar, so towards the palm angulation of the distal fragment at the neck of the shaft. A mallet deformity occurs when there is forced flexion of an extended finger, and this results in a tear of the distal end of the extensor tendon. But this is normally a clinical diagnosis because the patient normally arrives and is unable to voluntarily extend the distal interphalangeal joint. So on this image, normally there's a drooping of the terminal phalanx, and here we can see there's an avulsion fracture, and this is at the dorsal aspect of the base of the terminal phalanx. So a volar plate fracture is where there's forced extension of a finger. If you don't see it on the other views, it's important to include the oblique because sometimes it's best demonstrated on that view. It's the avulsion fracture is on the volar or the palmar side. So here you can see just that little avulsion fracture. If the fractures are displaced, they tend to again be unstable. A Boutonnière's deformity is a flexion of the proximal interphalangeal joint, and this is combined with a hyperextension of the distal interphalangeal joint. The finger at the proximal interphalangeal joint can't straighten, and the fingertip can't be bent, and this results in joint swelling and pain. It's also quite often seen in patients with rheumatoid arthritis. So skiers or gamekeeper's thumb. This is a disruption of the first metacarpal phalangeal joint of the ulnar collateral ligament with an avulsion fracture on the ulnar aspect of the first metacarpal joint, and often there is a subluxed first metacarpal phalangeal joint. Carpometacarpal joint dislocations are often associated with fractures and is through the bases of the metacarpals, and especially the first and the fifth carpometacarpal joints must be scrutinized very carefully to exclude any dislocations. Phalangeal fracture dislocations. So most dislocations tend to be dorsal. So if we look at this image, you normally define the movement according to the distal part, and you can see that it's dorsal with associated fractures. This can result in reduced motion of that joint with significant loss of function to that digit. Crush fractures are common with the terminal phalanges. The nail bed injury is normally treated as a compound fracture. So subungual, which means under the nail, if there's a hematoma plus a fracture, it then becomes an open fracture. So in conclusion, it's important that you always consider the mechanism of injury, as that can inform you of the associated pathology you need to search for on your images. Also apply your search strategy, and it's really important with the hand and the fingers so that you are able to distinguish what is normal and what is abnormal. And then get to know the common fractures and dislocations of the hand and fingers. And also important is to search for avulsion fractures, because that can indicate ligament or tendon involvement. Thank you.